Good morning. Today we are having a lecture regarding the TMJ ankylosis. I am Dr. Mulla Misbah Fareen, Senior Lecturer at SMT Dental College and Hospital. So today's topic of content is we will have first an in-depth knowledge of about definition of ankylosis, its classification, etiological factors, sequelae of TMJ ankylosis, diagnosis, clinical signs, symptoms, and management. So by definition, ankylosis refers to the partial or complete inability to open the mouth which results in functional growth and growth deformation of the mandible. Now how we can classify ankylosis by 4 to 5 ways. First is false or true ankylosis according to intra and extra-articular ankylosis. According to the type of material which causes ankylosis, it is fibrous or bony. According to the location, unilateral or bilateral ankylosis. According to the extent of ankylotic mass, that is partial or complete ankylosis. Kazanjian in 1938, it classifies ankylosis into part, that is in true and false. True is also known as intra-articular, which means a fibrous or bony adhesion between the articular surfaces of the TMJ. Now false ankylosis, also known as extra-articular ankylosis, which results from pathologic condition outside the joint that results in limited mandibular mobility. Now we'll have a look on another type of classification, that is fibrous, fibroosseous and bony. As I had already said regarding the material of the ankylosing mass. Another type is partial to complete according to the extent. Now true ankylosis, it is an intra-articular problem on account of fusion of the articulating surfaces of the head of the condyle with the glenoid fossa. Fusion can be in the form of fibrous union or bony union. Now we'll have a look on etiological factors causing the ankylosis. The most common etiological factor is trauma. This is the most common cause of ankylosis. Trauma to the chin forcing the condyle against the glenoid fossa, particularly with the bleeding into the joint, can lead to ankylosis over the period of time. Second most common etiological factor is infection. Infection from the middle ear and mastoid process, also known as otitis media or mastoiditis, can cause ankylosis. Inflammatory reasons are primary inflammation of the joint, secondary to local inflammatory processes, also known as osteomyelitis, generalized osteomyelitis, can lead to ankylosis in TM joint. Secondary to bloodstream infections can be reason is septicemia, scarlet fever, gonorrhea, and rheumatoid arthritis. More advanced things are neoplastic reasons. Congenitally, TM joint can be ankylotic, and myogenic. What do you mean by myogenic? Myo is related to muscle. So myocytic ossificans produces limited opening, so that lead to ankylosis. Neurogenic causes may be because of epilepsy and brain tumor. Now we'll have a look on clinical features. It includes it's subdivided into three parts: general features, unilateral features, and bilateral features. As we know, TMJ is a paired joint, right? It's like both we have. So that's why the clinical signs symptoms are also unilateral, bilateral according to the extent of ankylosis. Now, what are the general features of ankylosis? According to age, it's mostly seen in the younger age group, that is 1 to 10 years of age. Clinically, patient will come to oral surgeon or dental surgeon. They will report it nearly by the age of 8 to 9. Parents will start observing that the joint is not opening properly if it is congenital. Then symptoms, it's mostly the most prominent symptoms is trismus, which means by inability to open mouth. Oral problems related to ankylosis cause the trismus. First most common is poor oral hygiene. Why poor oral hygiene? Because they are not able to maintain the hygiene by brushing, because inability to open the mouth. And this lead to carious teeth, periodontal problems. Malocclusion is again, we'll see why malocclusion is manifested in ankylotic patient ahead. Now, unilateral ankylosis. In this picture, you will see patients suffering from unilateral ankylosis. What are the clinical signs symptoms? First is mouth opening is very limited. Here, if even this is a diagram, it's a pictorial picture, but if you would have seen patient in real, patient is not able to open mouth completely. Then asymmetry of the face with fullness of the affected side and relatively flattening of the unaffected side. So here the right side of the patient is affected by ankylosis, so there is a fullness, and the left side has got flattened. The face is deviated toward the affected side. So in this picture you could very easily see the patient's face is deviated toward his right side. Chin is retracted on the affected side and slightly bypass the midline. Slight gliding movement toward the affected side and crossbite is present. So this is an intraoral clinical sign symptoms. Well-defined antigonial notch on the affected side. Now what do you mean by antigonial notch? This is a notch which can be seen in OPG or cephalometric analysis. It's a notch, radiological feature where you can see on mandibular symphysis and parasymphysis region here, the joining point between them. So it become well defined. These are MCQ questions you have to be mindful of. Please note it down. So now we'll see bilateral features of clinical sign symptoms of bilateral ankylosis. Now here is a picture of bilateral ankylosis. So what you see, what is the difference between previous picture and this? The most prominent feature what we see is bird face appearance, or you can also call it as micrognathia. See the patient's chin is retruded, is giving face like this. So no gliding movement, neither protrusive nor lateral movement is possible because it's like both the joints are affected. Presence of scar on the chin possibly due to trauma. So now most common, as we have discussed in etiological reasons of TMJ ankylosis, one of the trauma is while giving birth. While birth, in previous days, they used to use a forceps for forceps delivery. So while delivering by forceps, if the forceps is being held on this region, just in front of external caustic metastasis, so that this could lead trauma to the TM joint, developing TM joint, and there you will see a scar mark also. So class 2 malocclusion, protrusion sizes and anterior open bite. Okay. In a long-standing case, there is atrophy or fibrosis of muscle. So why? Because there is, patient is not able to open mouth for long years, since many years, so the muscle become atrophic. So disuse atrophy you must have heard of. In congenital case deformity, difficulty of introducing the nipple into the mouth of the newborn infant. Now we'll see histopathology of ankylosis. Atrophy or destructive changes in the cartilaginous component of the joint with loss of meniscus. Now we know all, we have seen what is meniscus, so how does the anatomy of TMJ looks like. So you can correlate it with it. Normal soft tissue is replaced by thick fibrous bands and overall flattening of the articulation. Glenoid fossa and articular eminence become less prominent, right? The condyle become enlarged, composed of dense sclerotic bone. Now, how you will come to know what all investigation modalities you will use to diagnose ankylosis. For definitive diagnosis and to confirm the extent of bony growth, imaging may be required, which the most common is lateral oblique view. It's cheaper, available on chair side, you can do it. Next easy, convenient, economical way is your OPG view. In that you can see bilateral, both TM joint can be seen. Cephalometric radiographs, submendovertex view and PAV. Most advanced nowadays, like it's available, but economically it's bit at the cost is on a higher rate. Scale is CT scan, but this is something definitive diagnosis. You can see the soft tissue and hard tissue both. So this is a OPG. You could appreciate on the right side the arrow marks showing, fibrotic mass, and there is a loss of anatomy of TM joint. So osseous ankylosis, arrowheads between coronoid, the process and zygomatic arch, metallic sutures are seen. From a previous trauma-related operation, you can see, this is a you can appreciate the metallic plate. So this is the another picture is of modified Townes view. Again, you could see on right side of TMJ ankylosing mass. A mass of bone in the same mediolateral position and right coronoid process. Appreciate the arrowhead, which is of now white color. Mandibular midline deviates to the right side, see, affected side, because this is a unilateral ankylosis. We have seen in clinical signs symptoms of unilateral ankylosis. Now, what are the findings? Decreased ramus height on the affected side, because obviously, its growth is not completed, and we know in functional matrix theory that condyle has got a growth matrix in that. So if it is affected, growth is hampered, and so the ramal height is also decreased. The joint space is completely or partially obliterated with dense sclerotic bone. The condyle can be replaced by shapeless mask of bone. Prominent anticonial notch in the affected side of the mandible. These findings you have to find in investigation modalities, and then you can confirm it that patient is yes suffering from ankylosis. Elongation of coronoid process. This is very common because there is a law of nature. If some atrophy is happening, the another part grows more than its usual size. So to compensate it, nature has made this phenomena. So elongation of coronoid process happen. Sometimes it transfers or oblique dark line crossing the mass of the dense bone showing fibrous ankylosis. This is another investigation. This is lateral tomogram, which shows the continuity between coronoid process. Appreciate the arrows and the zygomatic arch that has replaced by bony mass. This is something of grade 3 ankylostic mass, which you cannot differentiate between the zygomatic arch and the coronoid head, condyle, even the coronoid process. The condyle is flattened and eroded. Appreciate the C in photo, your radiograph. There is a complete flattening of the condylar head. This is a 3D structure which shows osseous ankylosis, shows bone mass extending medially from ramus to the base of the skull. Appreciate the asterisk mark. Now, unaffected side of TMJ. These are the closed mouth views, axial CT scan. See the unaffected side of TMJ. How does it look like? Shows well corticated condyle. Sees the condyle, normal condyle within the clinoid fossa. Now, another diagram is affected side. Parasagittal CT. See, this is again unaffected side of TMJ. Condyle is denoted by C, which shows no change of position in the glenoid fossa, and this is affected side C, which is of type of fibrous ankylosis. The condyle shows erosion and osteophyte formation. Now, what is sequelae of ankylosis? Now, the patient is suffering from ankylosis. Now, what all other things are sequel will happen to the patient? Normal facial growth and development is affected. Speech impairment, obviously, because there is no complete growth of the mandible or ramus, so there is inability to positioning of tongue, so speech pronunciation won't be proper. Nutritional impairment, this is but obvious because patient is not able to open his her mouth completely, so nutritional deficiency. So respiratory distress because of lower seating of mandible is not completely formed, so your tongue is posteriorly placed, so patient is not able to breathe. Malocclusion, we have already discussed this. Poor oral hygiene because of inability to open mouth and keep the hygiene proper. Multiple caries tooth because of poor oral hygiene, and aesthetic impairment, that is obvious because facial growth is not proper. Now, because of all these factors and the patient suffering from a young adult, now they are in their teenage, they are going to enter in teenage and they will notice this abnormal facial growth. So that can lead to psychological distress. Now, what are the modalities we follow for management of TMJ ankylosis? Ankylosis can only be treated surgically. There is no form of pharmacological management for this disease. The type of surgery depends on the patient and extent of deformity. Treatment also varies if it is unilateral or bilateral. Now, surgery for ankylosis is done in two stages. First, operation only a release of ankylotic mass is done and jaw mobility is brought about. Then it is believed that growth takes place after releasing of the ankylotic mass. Second procedure, an orthognathic surgery, can then be planned to restore facial aesthetics, especially in children. So now by these are the mota modalities how we do. But now what is our goal to achieve through these surgeries? First is to create a mobility in the joint to a satisfactory limit, to restore vertical height of the ramus, to restore the mandible, and TMJ to normal anatomic and functional state, to create a new joint space, to allow the jaw to grow normally in child treated for ankylosis, to restore the facial aesthetic, to prevent recurrence of ankylosis. These are our goal. Now, thank you. We will see the surgical modalities through picture in next lecture. Thank you.